This presentation summarises the key recommendations of the NCEPOD report Time Matters, which reviewed the care provided to patients who were admitted to hospital following an out-of-hospital cardiac arrest. The report was published in February 2021. NCEPOD was given access to the out-of-hospital cardiac arrest outcomes registry data for 2018, the same period as the NCEPOD study. This illustrates the scale of the problem. The emergency services attempted resuscitation almost 31,000 times that year. It also sets the NCEPOD study in a wider context. Registry data shows that just over half of these patients were transferred to hospital, and 56.8% of those had a return of spontaneous circulation at hospital handover. This was the group of patients studied by NCEPOD. NCEPOD took a sample of just over 1,000 of these patients for in-depth review of the care they received. The review focused particularly on in-hospital management, but inevitably data were available on the pre-hospital management of the cardiac arrest. The first priority following cardiac arrest is to restore the circulation. This involves identifying that a cardiac arrest has occurred, initiation of cardiopulmonary resuscitation, and defibrillation. Many cardiac arrests are witnessed. Registry data showed that this was the case in 61.4% of cases. Registry data shown here also illustrates the importance of bystander CPR, which results in markedly improved outcome, and also the importance of defibrillation for shockable rhythms. NCEPOD data showed similar results when compared with the National Registry. Survival rates to hospital discharge were markedly higher when bystander CPR was performed. When the initial rhythm was shockable, 50.8% of patients in the NCEPOD study survived. NCEPOD therefore recommended that public health priorities include strategies to improve rates of bystander CPR and the use of public access defibrillators. There were 21 patients included in the NCEPOD study who received CPR despite having a community DNA CPR order in place prior to the cardiac arrest. Electronic systems to record advanced care directives were in place in 65 out of 178 hospitals. Where these were in place, they were shared with general practice in 36 out of 65 hospitals and with ambulance services in only 23. NCEPOD therefore recommended systems to ensure advanced treatment plans are shared across all healthcare services. Improving survival rates depends on the provision of high-quality post-resuscitation care. A number of factors impact on survival rates, but none should be used on their own to prognosticate. For example, time to ROSC less than 20 minutes resulted in a survival rate of 50%, and only 6.3% survived when this took longer than 20 minutes. However, the longest interval between cardiac arrest and sustained ROSC in a survivor was 39 minutes. In-depth review of the case notes also showed that the documented time to ROSC changed during the hospital admission in just under 12% of patients. pH falls with circulatory failure, and there is a broad correlation between the time to restore the circulation and initial pH. This chart shows pH on the first blood test after hospital arrival. Almost 10% of survivors had an initial pH of less than 7. Similarly, data in the report also showed that the highest admission lactate in a survivor was 19.8 millimoles per litre. NCEPOD therefore recommended that no single factor is used to make decisions about organ support following out-of-hospital cardiac arrest. Following return of spontaneous circulation, the majority of patients remain unconscious or confused. Airway protection and neuroprotective measures are often provided in critical care. This enables formal assessment of neurological prognosis. The NCEPOD review found that formal neurological prognostication was only undertaken in the minority of patients where it was indicated. The accuracy of prognostication is improved when more than one approach is used. The review also found that there was room for improvement in the process of prognostication when this was done. As well as the process of prognostication, the timing is also important. Accuracy is improved if the process is delayed for at least 72 hours after return of circulation. There was also room for improvement in the timing of prognostication. 2 recommendations were therefore made to promote better practice in neurological prognostication. The first of these focused on the neuroprognostication process, and the second on the timing of prognostication, as well as ensuring that other factors that can influence neurological assessment are taken into account. Guidelines in place at the time of the study promoted the use of targeted temperature management to improve neurological prognosis. The precise temperature to aim for, and even this policy itself, remains a subject of debate. The NCEPOD study showed that guidelines were frequently not followed when this approach was indicated. Reviewers considered that the approach to temperature management was poor or unacceptable in the majority of patients. A recommendation was made that promoted the application of the guidelines in place at the time of the study. Optimising the outcome for survivors of out-of-hospital cardiac arrest once they have survived the initial phase of inpatient care involves various aspects of rehabilitation. Organisational data showed that cardiac rehabilitation was almost universally available, but there were gaps in the availability of neurological rehabilitation and, in particular, psychological support. An assessment of the need for physical rehabilitation was made in 71% of survivors, and for neurological rehabilitation in 29%. Cardiac rehabilitation was offered to 59% of survivors within 3 months of hospital discharge. Only 20% of survivors were offered psychological review. A recommendation was made that promoted access to all forms of rehabilitation, including psychological intervention, for out-of-hospital cardiac arrest survivors. The case reviewers rated the care of patients included in the study as good in 50% of cases. There was room for improvement in clinical care in 36.5% of cases, and in the organisation of care in 15.6%. The full report can be accessed via the NCEPOD website at www.ncepod.org.uk. Resources available include the infographic shown which summarises the contents of this presentation.